Welcome, everyone. Thank you for the hearts for folks that know that song, know what the message is about. For those who have never heard it before, I really encourage you to take another listen. Um, just wanted to start off this meeting that we have in November during a week of a lot of things happening um, to remind us that community space is important and it is necessary for us to stay engaged in the work that we're doing and to know that we're not doing this work alone. So thank you for being here with us today. My name is Heather Redmond. I use she, her pronouns, and I'm the Strategic Initiatives Partnerships Coordinator within the Public Health Division. And I'm going to pause my talking for a minute to let Dolly introduce herself. If you have not been introduced yet to Dolly, you're in for a real treat. Dolly, go ahead.
Hi, and good morning, everyone. Dolly England, she, her queen. I am the Community Engagement Strategies Manager in the Equity Office. Good morning. Good morning. Heather, do you have a warm-up question for us this morning?
I did not come up with a question, but I was hoping that folks could be flexible with us this morning and introduce themselves in the chat like usual. Just because I looked at the content of our super awesome presenters and I want to make sure we have enough time for folks to absorb that content and ask really awesome questions. So if you think of a warm-up question, Dolly, please put it in the chat. But I was just going to ask folks to introduce themselves in the chat.
I would love folks to introduce themselves, give us your name, pronouns, organization, and how about we do a word for how you're feeling this week? Tell us one word for how you're feeling this week. I am going to say I have eaten a lot. Eating is my word. Eating.
No, don't do that.
Mm, I'm
Um,
I'm gonna
I
do it.
feel, gosh, so much. Um, Disappointed and deeply sad.
So, as folks are entering your name, organization, pronouns, and a word to describe how you're doing this week into the chat, I will happily hand it back to Heather so that we can get this meeting on the go. We've got a lot of information to share and some really awesome presenters. So, Heather, I will hand it back to you.
Thanks, Dolly. And I'm not going to take up any more time together as a group, and I'm going to hand it over to our presenters. They will introduce themselves, but we are here to talk about the State Health Assessment, also known as the SHA. So, presenters, please take it away and let us know who you are.
Oh, good morning. Um, this is Jamila. My visual description is I am a white lady in what I am calling the peak 30s. My eyes are likely puffy. I got my hair blown out yesterday. It looks great. It's not going to look better than this. So please just know that. I use she, her pronouns. I can't ever remember my job title. I'm helping with the state health assessment. My word is grateful. And I woke up this morning and I realized like it is my literal job to uplift community voices and put them into our system and put community perspective into our system. That's my job. So I'm going to do that no matter what. So I feel grateful. Dean, would you like to introduce yourself before we go to the slides?
Or I'm Dean Seidlinger, he, him, his pronouns. Um, visual description, I'm a middle-aged white male. I cannot claim 30s by any source of the imagination. Fluffy hair, not because it was blown out, but that's just the way it is, and it will not look better than this, and it doesn't look good today. So this is what you get: gray and brown hair. I have the privilege of being our health officer and state epidemiologist, and I'm here today because Jamila told me to come. But I am excited to talk about something that seems rather, you know, boring, the state health assessment, and tell you why you should be excited and how this is really going to help us.
This is Jamila, true
Oh, and
story.
tired. Tired was my word.
Tired
So,
was your word. Okay. We can all take a beat, take a rest, take what we need. Let's share screen. Thank you so much, Heather. I'm Jamila. For those of you who've seen this presentation before or have heard me give this spiel, feel free to add comments in the chat throughout. We love questions throughout, and we are here to be in community and make this an information share that is useful and accessible to you. So if I'm speaking government jargon or it's not connecting, let's talk about it. Let's work through it. Um, Hello. We are here today to talk about the state health assessment and the state health improvement plan. Next slide, please. Hello, Jamila and Dean. We're here. We're going to talk about the things. I'm going to talk about the state health assessment government-y things. Dean is going to talk about the data-y things. And we're gonna get through it together, y'all. Next slide, please. Okay. We'll talk about the state health assessment, which is done every 5 years, our state health improvement plan, which is a plan we work from for 5 years, and we'll talk about ways you can get involved. Again, I woke up this morning thinking about how we get y'all's voices into our systems and the work we do every day. And we'll talk about questions, concerns, the realness. Next slide. We love our acronyms. Here are some common acronyms I might use. I might say CBO, and this means community-based organization. I might say LPHA. This is our local public health authority. Many folks call this the health department. I might talk about OHA. OHA is a giant bureaucracy with like 5,000 people. I am part of the Public Health Division, which is PhD. The work we are currently doing and going to talk a little bit more about sometimes is called SHA. For those of you who are around during COVID, this is kind of confusing because you might have heard SHA used differently. In this context, it's state health assessment. For bonus points in the chat, if anyone remembers SHA from COVID and wants to put it in the chat, feel free. SHIP, we talk about our SHIP, our State Health Improvement Plan, and to keep things just a little bit confusing, HTO, Healthier Together Oregon, which is different than Healthier Oregon. HTO is our 2020 to 2024 State Health Improvement Plan. Yes. All right, let's do a quick pop quiz. True or false? Oregon does not currently have a state health improvement plan. True or false? I'll give folks a minute in the chat. False, false, false,
Like
false.
people think it's
Excellent.
false. I'm gonna go against the grain and say true.
Wow. Well, all right. Well, thank you, thank you, thank you. The answer is false. Can't win them all, Dolly. Can't win them all. So we do have a state health improvement plan. It is called Healthier Together Oregon, and we'll talk a little bit more about it today. True or false? The work of the state health assessment only happens within the public health division staff. True or false? Thank you, Betty. I see a false from Betty. That's right. Here we go. All right. It is false. You're involved. You're involved. I see several steering committee members involved. If you are a steering committee member, please, if you feel moved to do so, say hello. My name is so and so in the chat. I'm a steering committee member. This is a cross-sectional work stream that we partner with community and folks across state government and all sorts of entities to do. This truly is the story of health in Oregon, and we can't tell it alone. So we really need your voices. Next slide. All right, I'd like to share a little bit of context about these words I'm throwing out and using. So we in Oregon, as with many states, participate every 5 years in state health assessments, which then lead to state health improvement plans. I want to direct your attention to 2018, the before times. In 2018, we did some really cool stuff and we changed the way we did the state health assessment. We hosted listening sessions and we provided community partners with funds so we could hear more broadly than we had in the past about what community really cared about and their stories of health in Oregon. We took this information and we developed the Healthier Together Oregon State Health Improvement Plan. As you can see, that came out in 2020, and we'll talk a little bit more about what that contained and some of the lessons learned in that work. As part of the 5-year plan, we are currently doing the state health assessment, and we're going to be wrapping up that work in early 2025, where we will then transition into a state health improvement plan for 2025 to 2030. And in 2028, we will do the SHA again. So just wanted to share a little bit about the timelines of this work and set us up for this conversation. Next, before COVID, let's talk about the state health assessment. All right, so what is the state health assessment? Broadly speaking, it's a giant document that helps us tell the story of the health status, health data of people living in Oregon. We work with our steering committee to identify the health priorities and the health assets in Oregon, and we work with many of you across the state to identify how prepared our state and counties are to address these health priorities. If you would hit next. Many of you may have already contributed. I know many of you may have participated in the public health system workforce assessment. You might have provided input on your local community health assessments, your CHAs. We are working to pull information from CHAs and incorporate it into CHAs, Community Health Assessment. We're working to incorporate that into our SHA. And community input. Many of you may have had conversations with the READ group or different OHA staff. We take information from those papers and evaluation reports, and we put them into our state health assessment. I kind of call this a big report of reports, a report filled with reports. Next slide, please. Let's talk about what the state health assessment does. And it really gives us an opportunity to reflect on public health indicators, gather information, and we share it with our steering committee, and they help give us context and direction. And we share it with Oregon Health Authority leadership. It's a foundational document for giving us insight into how we create our state health improvement plan, and it's part of our accreditation efforts. Next. All right. So let's talk about what it doesn't do. So this isn't necessarily a scorecard or a full evaluation of our previous SHIP. Next. No new data collection. Next. Very good. So this one, we're doing things a little bit different than the 2018 SHA cycle. And I wanted to be transparent and real about some of our limitations and some of the strategies we're hoping to take to incorporate community voice into this process. I heard or saw someone mention lots of focus groups. We absolutely held lots of focus groups in 2018 for the previous SHA. For this cycle, we had to make choices about capacity, and we have chosen to host those potential listening sessions and conversations in the spring and summer of 2025 to help give direct input into our state health improvement plan, our SHIP. Next, please. Let's talk about how we're doing this work. I see there's a blend of internal and external folks. I have a couple versions of this slide. It's very busy. We have internal work we're doing and we have external work we're doing. This is a little bit about the external efforts we're doing. One of our biggest focus areas is working with our steering committee. And this is 27 members from across Oregon who reflect many of the priority population communities. We have a lot of lived experience, and I was just looking at the list. Most folks are residing or connected to areas outside the Portland metro area. So a lot of interesting input and really powerful insights from across the state. Next. And externally, we're doing community engagement. If you have a space where you'd like to host this presentation or have this conversation, let me know. We are providing presentations and gathering information. And also, we have some funding opportunities that I want to highlight. We had a presentation this morning at 9 a.m. We'll have an info session later today at 3 in Spanish, and we'll have another presentation on the 20th. I will drop these links in the chat, and they will definitely be available. Next slide, please. Let's talk about how you, at this point, can get involved. I am collecting information from folks about what does being healthy mean to you, and what does it take for your community to be healthy, and how do you define community? For me, that one's definitely very interesting because I think we use that term a lot in the public health division. Oh no, did I freeze? Oh no. Okay, sorry. Everybody was looking very serious. I'm like, oh no. I think we use the term community a lot, and I think we can and should dig into what that means, and how we use that in public health. So there are a couple ways for you to provide this input that will be shared with the steering committee. You're welcome to add it in the chat. You're welcome to raise your hand and share, or if you would like, you're welcome to fill out our Survey Monkey, and I will find that link and share that with us in that way. Is there anyone who would like to unmute and share any of their thoughts around any of these questions? Dolly, how do you define community?
It's really interesting as I sit here, kind of in my feels. I'm thinking community is going to be there who shows up when the going is good and when the going gets rough. Regardless of how much money we might have, this is who's going to be keep showing up no matter what. And I also feel community is a feeling as much as an actual thing. There is a feeling that comes with community. I see you unmuted, Dr. Sandra.
Hey, Dolly. Wow, that's a great definition for community, which I really agree. And I would add, we might have, and that's the good, I think. We might not, we do have differences in everything, and not just, our skin color, our background, origin, but we have different ways of thinking and viewing the world. So this is community for me when we cannot just have the same together, but also being able to share these differences. And wow, and how can we work together? That's become a community. Like here, I feel this is a community. Thank you for providing this, Dolly, and every staff at the PhD, Jamila, and everybody.
Well, if Sandra's going to talk, I'm going to have to talk because that's just the way we do things. No, for me, community is caring for people who we normally easily turn our backs on. I just had this situation this week where we've got this delivery program. We have no money. There's no money for it, Betty. We got to shut it down. We got to shut it down. But then, you go to bed thinking, but we're shutting down the elderly and the disabled is what we're talking about right now. So we don't have any money, but you know what? We got to figure out how to get the money because if I'm enjoying Christmas, I need to know people who are elderly and disabled, homebound are also. So I feel like community is caring for those who we normally easily turn our backs on because we just don't have the money. Well, not having the money is not a reason to not provide our community with what they need. So I think community is especially caring for people we can easily turn our backs on, but we refuse to because they're a part of our community. That's what I think. Sandra and Dolly and Jamila. Oh, by the way, we got the money. I went to a group of people and say, you know what? We blah, 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 blah. And before I went to bed that night, we had thousands because we can't turn our back on people. Anyway, that's
Think you got your answer. There's a lot of answers in the chat.
Whoa, whoa, listen. Thank you. Thank you, Dr. Sandra, and thank you, Betty. I know both of you. You always find a way. You always find a way, and I really appreciate that.
And Jamila, if you allow me just one more, because I put something there, like related with how it takes for your community to be healthy. Don't leave nobody behind, no matter of their lack of formal education or capacity. That's how we can make the community healthy.
Thank you. Thank you. All right. Well, I'm so sorry if you can hear that yippy little dog. Next slide, please. With that, I'm actually going to transition it to Dr. Seidlinger to talk about how we use data to tell our story.
Thanks, Jamila, and thank you all for the comments. I think it's really helpful, and it's uplifting. I think this week to hear those conversations and the determination and the fact that we're going to get through this and we're going to go forward together, all of us. Um, So I'll pause here for a moment and say, the state health assessment can sound like a rather bureaucratic document. And, we do base it on data and statistics about the health status of Oregonians. And incorporated into it is a list of data that we call state population health indicators, which sounds very bureaucratic. And when you look at it, it looks a little bureaucratic. There's 140 something different pieces of data, and that one isn't all the data that we have. It doesn't tell the whole story, and it certainly doesn't um, present community input and community views and the prioritization that we've heard from our own staff, from our community partners, from our local partners on the ground doing this work. So the state health assessment is going to look a little different this year. Yes, we evolved it last time. And then, we finally came to the table. You'll hear a little bit more about our state health improvement plan, but after years of focusing on some health outcomes that are extremely important to health, like, okay, what's the childhood immunization rate? How many people were diagnosed with chlamydia? How many people's weight is not at a healthy weight that might put them at risk for cardiovascular disease, diabetes, and cancer? Super important. But we don't start with those. Like, people don't start with like immunization. We start at home, in our neighborhood, and can we pay the rent? Can we get healthy food? Do I feel safe in my neighborhood? Do I feel respected by the people in my neighborhood, by the people I work with, by the people at school? And so, the last the Healthier Together Oregon, our last state health improvement plan, really pushed us upstream. So I think what you're going to see as our data comes out as part of this state health assessment is that mixture of some of those bigger upstream things that impact our health, economics, whether we have a roof over our head, kind of stress and toxic stress and how that may impact us, to some of the more traditional health outcomes, because I think we still need a way to measure things. Like, we can have a plan to address, houselessness, but we're not going to we're going to make progress in 5 years, but we're not going to solve it. But can we look at houselessness and how that may impact someone who has a substance use disorder, who trades sex for drugs and gets syphilis and then gets pregnant? We can address that, from public health. There are specific interventions. While we address some of the houselessness, try and get treatment and other things, we can test them, treat them, make sure that their baby doesn't have syphilis. So you're going to see a mixture of some of those kind of broad issues that we need to continue to work on and slog through, smaller issues. And we're not going to fix syphilis in 5 years either. So don't get me wrong, but it is a little more manageable, and I think something where public health has a little bit more of the responsibility than we do for kind of poverty generally. So we picked just a few indicators, and I want to talk a little bit about kind of what they show, the kind of questions that it raises, and how we might talk about these in the state health assessment we're currently doing. So let's go to the next slide.
Dr. Seidlinger, may I
Yes.
say one thing? I
Yes.
This health indicator data, these I want especially CBOs to pay attention, because these will be showing up in the 2025 request for grant applications. And we are currently building our next grant to align with these indicators. So I'm planting a seed for what's to come. Please go forth, Dr. Seidlinger.
Thank you. And I will say these three indicators themselves may not be the ones, but you'll see indicators from our list and topics show up. At least one of these will likely be a core piece. But there are pieces that we're all working towards, even if this precise data point doesn't come in. So we're going to a little bit define what the indicator is. So what are we measuring? How are we measuring it? Because there's some great ideas that people are like, you should be reporting on this. And we're like, we should be, but we don't have access to that kind of data. So I think you'll also see us telling stories to kind of round out the indicators as we go around and talk about the state health assessment and how it feeds into the state health improvement plan. We're going to highlight current opportunities for improvement, and there are a lot of opportunities out there, as you probably know, because you're all working with your neighbors and friends and loved ones, and know that our health is not what we would all like it to be. And then discuss how the indicator is tied to health equity goals, which is, at OHA, elimination of inequities in 10 years. And we're committed to that. Will we get there in 10 years? Probably not, but we're going to be closer. So with that, let's go to the next slide, which I think. Oh. So this is how we kind of set up some of the indicator data on these slides. So why this is important to our health equity goals and outcomes in terms of quality of life. So how are people in Oregon affected by this? This isn't a number. This isn't a point on a graph or a bar on a graph. I mean, these are people. These are our neighbors. These are our family members. This is us in this data, and we have to remember that. So when we say an indicator is getting worse, that's more people being impacted by that. Who is even more likely to be impacted, and how does this affect the opportunity to kind of lead a full um, to achieve health and wellness in our state. So we'll try to define the indicator there and then give a statewide status, rate, or value. And then you'll see we'll go into a little bit of some of the breakdown of these indicators. Next slide. So childhood immunizations. One of the greatest achievements in public health is immunizations. The problem is we did such a great job preventing a lot of these diseases that now people are starting to question, like, well, why do I need these? And so, when we prevented, millions of infections and, hundreds of thousands, if not millions of deaths worldwide from immunizations, it's hard to kind of for people to grasp that. Like these horrible things would have happened had we not had immunizations. So most immunizations are given in childhood. Children are more likely to have serious complications from many diseases. So we want to give them protection as early as we can. So we give these protections in childhood. They often require a series of vaccines to get full protection. And when kids don't get these immunizations, they increase their risk of illness. And some of them may have mild illness. Some of them may have more serious illness and need to be hospitalized. And tragically, we see people who die from vaccine preventable diseases, including in this country. Delaying them could disrupt employment and childcare for parents. And, that's critical. Like, I don't want to break it down to dollars and cents, but, parents often struggle if a child needs to stay home, see the doctor, be sick for a while and can't go to childcare, and having to choose between that paycheck and doing what they need to do to care for their child presents real dilemmas. It's costly for families. It's costly for the healthcare system. Preventing disease is so much easier than treating disease, and it can exacerbate disparities that we see between populations. So one common indicator is to look at the percentage of 2-year-olds who are up to date on their immunizations. And so we receive a lot of immunizations in infancy, around 1 year, 15 months, and 18 months. And so we look at 2 years to see who got all the immunizations we recommended. And you can see here, we're at about 68.3%. So a little over 2/3 of Oregonian children are up to date as of 2023. And we're below the US average of 69.7. So we have some work to do to just be average. And, we'd like to be above average. So next slide. How does this look across kind of racial and ethnic groups? I will say this slide, which is pulled from our immunization information systems, uses federal categorizations of race and ethnicity. So, often lump some folks together. I think in future, we'll see a little more granularity in here where people will be able to see themselves more in these categories and not necessarily lumped together as much. And as it says below, the AIAN is the abbreviation for American Indian Alaska Native. So who has received their immunizations at the highest rates? It's people who've identified as Asian, people who've identified as Hispanic, and people who've identified as white, all kind of above that statewide average. And then we have groups, our American Indian, Alaska Native um, children whose parents identify them as Black, and Pacific Islander kids whose rates are lower. So we have some work to do to close that gap. We have federal um, resources that provide vaccinations for children on public insurance and those who are uninsured. We have healthcare providers who care for kids who give vaccinations. Our public health authorities give vaccinations, and so a lot of opportunities to get that. But we still have kids who don't get them. Some of it is an access issue, and some of it may be, parents are skeptical of immunizations and are worried about the safety of immunization. So we have work to do on the education front. Next slide. This slide just gives an example of a couple different counties, and the county breakdowns are provided. And this shows on the left, I don't want to pick on folks, but Curry County, which has significantly lower vaccination rates for 2-year-olds than the state as a whole. So, if I was working in Curry County, kind of why is that? Start to look into it a little bit more. Is it access points that people don't have a convenient place to get vaccines that they trust? Is it just not a lack of belief in the importance of immunizations, kind of what's going on? And so, local partners who are doing the work can ask a few more of those questions and get into that. And then we look at Crook County on the right, which has tracked fairly well with the state average. When we see smaller numbers in some of these counties, which have less people, we'll see a little more volatility, a little more sharpness in those year-to-year peaks. But then we see that overall their vaccination rates are higher. So what have we done to get that up? What's working in Curry County or in Crook County, and what could other people potentially learn from? Next slide. Syphilis. I brought this one up because you're likely this is one of those ones, similar to that first one that Dolly said, pay attention, learn about this. Syphilis. It's a disease that's transmitted, it's a sexually transmitted infection. And for a while, a couple decades ago, we're like, we won the war on syphilis. Like syphilis rates had declined to next to nothing. And that was great because syphilis can cause lifelong problems for people who are pregnant. It can lead to stillbirth, so the death of the fetus before the baby's born. It can lead to infants who die after they're born. It is a very serious disease. And for the person who has it, it can lead to neurological problems and other serious complications. So why are we seeing syphilis rates go up? Well, one, we do what we usually do in public health. We kind of make a lot of progress on a problem, then we don't invest in it anymore, and then the problem comes back. So that's part of the issue is we haven't done that. But another part of the issue is, there are a lot of reasons people don't come in, report symptoms, or get tested. There's a stigma. If you have a sexually transmitted infection, how are people going to think about you when you come in? Are they going to judge you for, behaviors that you've participated in, for the number of sexual partners you've had? Many people don't have preventive care, don't go to the doctor on a regular basis for checkups to ensure they're healthy. And that, again, public health infrastructure, we made great progress on this. So we didn't invest in it as much. And that's not a choice that I made or Oregon Health Authority made. It happens all the time in public health from our federal resources and our state resources. And then new issues come up and we shift resources, but the pool doesn't grow. The pot doesn't grow. So all those things can lead to the rates of syphilis that we're seeing now. And so when we look at people who have a diagnosis of syphilis confirmed in the laboratory, about 26.3 people per 100,000 people in 2022. That rate is 17.7 overall for the US, and many states are in the same boat as us that are seeing these rising rates of syphilis. And then this concerning shift of more folks who identify as female having syphilis, and then that potential for impact on pregnancy and child outcomes. Next slide. So how does that look across racial and ethnic groups? An even more stark difference in this indicator than we saw with childhood immunization rates. With our American Indian, Alaska Native, and our Black non-Hispanic folks being significantly higher than the overall state rate, with several groups being below that state rate. So we have a lot of work to do here. And this isn't a genetic thing. This isn't because certain races are more susceptible, but this is those bigger factors we talked about. So, what are the economics? Are people um, stably housed and have a job and able to provide for their family? Are people addicted to drugs? Are they using drugs on a regular basis and need to find ways to support that, unhealthy habit as they're, when they're not in treatment? So we call that a syndemic. They travel together. This epidemic of substance use, this epidemic of syphilis, like sexually transmitted infections. One feeds off the other, and so we see, that in certain racial and ethnic groups being much more impacted. So we need to not just, you know, do laboratory tests, find out who has syphilis and treat them. Super important. But we also need to find out, why are these people more at risk? Why are certain groups seeing it more, and try and address some of those upstream issues. Next slide. So here's a breakdown to kind of walk you through that looks at syphilis incidence, so the rate of syphilis in by age, how old you are, and by gender, what sex you identify with. Right now, this is binary. Males identified by orange bars, females by blue bars on the left. Um, Older age groups on the top, younger age groups on the bottom, 15 to 19, all the way up to 65 or older. No one is spared, except perhaps maybe the 65 or older females on this graph. But we can see that much higher rates in males. Most age groups are over the statewide average. But we can see that on the female side, those rates are up as well. And that 20 to 24, 25 to 34, and 35 to 44, those are women of childbearing age, where not only does it have serious consequences for the individual, but if they do get pregnant, can have serious consequence for their child. So this is what we're dealing with, and we have to tackle this on multiple fronts. Next slide. And then I'll show you a different um, indicator here, air quality related respiratory illness. So think smoke in the air from wildfires. Even if you're distant from the wildfire, but you happen to be downwind from the wildfire, and that smoke comes in, that can impact our ability to breathe. Yes, if you're an older adult, or if you have an underlying medical condition like asthma, you may be more impacted sooner, but all of us, depending on the level of air quality, can be impacted. So this indicator looks at who's going to the emergency room, who's going to urgent care for an illness that is related to air quality. So reporting coughing, trouble breathing, other diagnoses that could be related to air pollution. Right now, that rate right now in 2022 is about 22 per thousand for Oregon. And what brings people in? Well, there's some kind of internal things that we have, how old we are, whether we have another condition. Is there a genetic factor that causes us to have a diagnosis that could put us at risk? Are we healthy? Are we eating a good diet and our nutritional status is adequate? Or is our nutrition bad, and we're not as able to fight off illness? And so we don't have that kind of status. So all those play in. But then the external pieces that lead to why people are coming in, are they stably housed? Are they somewhere where if we say air quality is really bad out there and you should keep your windows closed, but it's 100 degrees out, so in order to keep your windows closed, you need air conditioning. Um, but your housing doesn't have air conditioning, or you're like, well, if I turn the air conditioning on, then I got to think of what I'm not going to pay for by turning that on. So I'm just going to leave my windows open, and so your income, helps determine your housing. How stressed you are can put you at higher risk. And systemic racism, historical racism, where people live, where they're able to live, and how they're treated can impact, how they're going to fight off a disease. So all these things come together and put certain individuals more at risk for going to the ED when the air quality is bad. Next slide, because I know I got to turn it over to Jamila, so I talk too much. So when we look at air quality visits by group, again, the statewide average is about 22. And unfortunately, it's only my third slide, but people are probably not surprised that certain groups, see double that. Our Pacific Islander neighbors, our Black neighbors, and our neighbors who identify as American Indian or Alaska Native. And it's a lot of those factors from the previous slide probably a lot more of those external factors that are leading to this disparate visits. So how do we work on that? How do we get the resources to folks that they need to keep themselves and their family healthy and not have to make choices, at the time of an emergency to keep themselves healthy? Next slide. Um, this is just kind of looking at a couple counties. So statewide, the air quality related respiratory illnesses in 2023, you can see different shades, lighter shades, less people by population going to the ED or urgent care, darker shades, more people, and then presented a couple counties. The top one being Coos County, a coastal county, had very high rates of folks going to the emergency room. Hood River, another county on the water, but the river this time instead of the ocean, much lower rates. And so, what is leading to these? Part of it is out of our control. It's the wind patterns and other things, but part of it is are we doing a better job at getting resources out, messages out to people who are more at risk, and allowing them to take steps to protect themselves in these air quality events. So there's just a high level overview of what you're going to see in the state health assessment. There's going to be some just kind of lists of graphs and data, but then we'll try to put it into context in the text and talk about why we're seeing this, why we see the differences, and what we could all do to intervene. Next slide. And I have not been paying attention to the chat. Am I doing false too? I am. Mila, yes?
Maybe we could come back another time and talk
Okay.
about falls.
Falls, super important. We don't talk about them a lot, but if you're an older Oregonian, an older adult, and you fall, it can be really detrimental to your health. And there's some simple things we can do. Yes, we need to address economics and all that, but there's also simple things we can do. So stay tuned. Look at the slides. Reach out. We'll give you some guidance. Jamila, next slide.
For sure.
And then
Thank
next
you.
slide. Next slide. Here's we'll drop a link into the chat of where you can find the current indicators, though they're going to change. And then I'll turn it over to Jamila.
This is Jamila. Thank you so much. Next slide, please. Y'all, I we're setting some context and talking a lot today, but we hope to come back in 2025 to continue the conversation and continue to get y'all's input. Very quickly, I want to set the stage and talk a little bit about the State Health Improvement Plan. Next slide. So, as I might have mentioned 10 times before in this presentation, our current ship is Healthier Together Oregon. And if I was listening and hearing correctly, Dolly was dropping some Easter eggs that future funding is definitely going to be connected to our future state health improvement plan. And very importantly, we want y'all's insight. Let's talk a little because this informs our policies, partnerships, and investments for Oregon Health Authority and other agencies, including our CCO friends. Next slide. Very briefly, Healthier Together Oregon worked towards the vision of achieving health equity, and we worked with community to identify 5 priorities, 8 implementation areas, 16 ways that we were measuring progress, and 62 strategies, which were actions we were hoping to take to improve health in Oregon. Next slide. Here's a little bit about what community prioritized. To what Dean was saying, folks really focused on upstream social determinants of health and the things that really get in the way of living our best lives. And these include things like institutional bias, adversity, trauma, toxic stress, behavioral health, and the economic drivers of health, along with access to preventative health care. Next slide, please. This is where I want to be real. We rolled this out in 2020, and many of us spent 2020 on webinars together, working on health together. COVID-19 drastically shifted public health's capacity to focus on things like state health improvement because we were all in it together, focused on immediate threats to health. However, we did do some really cool, interesting, powerful work, including in establishing a partnership, which was our community oversight group. We provided small grants for our community health improvement projects, and we learned lots of lessons related to capacity, scope, and opportunities for deeper and better collaboration. We're going to be taking that into the spring and many of the conversations we have. Next slide, please. Let's talk about what's next. We are going to be working frantically over the next 2 months, realness, frantically to compose and integrate feedback from our steering committee into our state health assessment. We're going to be working very hard over the next couple of weeks to write this thing. We then hope to work with our steering committee and many folks like you to redevelop the state health improvement plan in the spring and summer. And circa 2025, late 2025, we hope to begin implementing our state health improvement plan. Next slide. Let's talk about how you can get involved. In the spring of 2025, we are going to take priorities identified from our steering committee out to community and get input. Once we get community input, we'll work with our steering committee to finalize those priorities. And then we'll go back to community and talk and share a little bit about proposed strategies to make those priorities happen. We're going to talk about strategies that we could use or take to fulfill those goals. And we're going to get your input. We're collecting that input in a couple of ways. Conversations like this, or maybe visiting spaces that you host and collecting input. We'll probably also have some surveys available. And importantly, we are going to be providing our community partners with some funding to do this work themselves. I dropped the links in the chat a couple of times for info sessions. We have an info session later this afternoon in Spanish. I'll drop that in the chat. And on the 13th, we have an info session. We have an info session on the 13th in English. We hope to have the application available on 11/20, and it will be open for about 4 weeks. Next slide. We have 10 mini contracts, and they are going to be worth up to $15,000 each. I've listed those dates and times here. Next slide. Here are some ways you can remain involved, and I'm sure we can get you these slides if you'd like them. Feel free to reach out to me as well. Next slide. All right. Thank you, thank you, thank you. I know we are just at time, but if anyone has questions for me or Dr. Seidlinger, feel free to write them in the chat or unmute. Thank you.
All right. Thank you. I will say thank you for myself. I will say thank you from the group, both Jamila Norton and Dr. Dean Seidlinger, for coming and sharing this really important information with the folks on this call. Dolly, thank you for your thought prompts. Loved those. And I know that you all are already asking a lot of those questions, and I can tell that your cogs are turning in your brain. I just want to get a quick check, emoji reaction check from folks. Jamila offered to come back in 2025 and do an update with more info and all the things. How do we feel about getting that on the calendar for next year? If y'all can just give me a reaction. Dolly, got a reaction from Dolly. I see some thumbs up. Amazing. Okay. More to come. We will make sure we will make sure that we bring our lovely presenters back. And as always, you will get the recording of this presentation, you will get the slides, and you will get the links to all of the amazing things that were put in the chat, so that you have access to those later. So be on the lookout for that follow-up email. Anything else from Dolly, Dean, or Jamila as we close out with this group for today?
Thanks for listening and thanks for getting involved. I'll lay that little guilt trip there because I think we need all of you to be as successful as we can be.
I couldn't have said it better. Take care of yourselves, everyone. Have a wonderful day.